Trichinellosis is the parasitic disease caused by the parasitic helminth species of the genus Trichinella, which is a zoonotic parasitic disease resulting from the consumption of meat from infected animals. Currently, 12 species have been identified, which are classified in two clades. The clade of the encapsulated species Trichinella spiralis, shown on the picture, Trichinella nativa, Trichinella britovi, Trichinella nelsoni, Trichinella mirelli, and Trichinella patagoniensis, and the clade of non-encapsulated species Trichinella pseudospiralis, Trichinella papuae, and Trichinella zimbabwenensis. Trichinellosis is a parasitic disease which is characterized by a wide range of hosts, including humans, mammals, and birds, as well as a cosmopolitan disease because it has a wide geographical distribution. Trichinellosis probably originated in wild animal population of the Arctic and subarctic regions. Later it was extended to the animal populations of the temperate and tropical zones. According to the World Health Organization, until the year 2009, there were more than 65,000 cases of trichinellosis in the world, with more than 42 fatal cases in the regions of Africa, South Asia, Europe, and America, mainly United States, Mexico, Chile, and Argentina because of its high infectivity. However, it is estimated that currently 11 million humans in the world are infected by the Trichinella species, mainly by Trichinella spiralis. In 2014, Food and Agriculture Organization of the United Nations, together with the WHO, published a list of the top 10 food-borne parasites that affect the health of millions of people every year worldwide, infecting muscle tissues and organs and causing serious health problems. Trichinella spiralis occupied the 7th place below parasites of medical importance such as Taenia solium, Toxoplasma gondii, and Entamoeba histolytica. Therefore, currently trichinellosis remains a foodborne parasitic infection of great medical importance worldwide, and its impact and magnitude of the problem that this parasitic disease represents become evident early in the appearance of epidemic outbreaks. James Paget, a medical student at St. Bartholomew's Hospital in London, England, observed a parasite in the diaphragm muscle of a 50-year-old Italian patient who had died from tuberculosis. Subsequently, the British zoologist Richard Owen in 1835 studied portions of muscle tissue of the Paget case and gave it the name of Trichinella spiralis. The adult parasites in Trichinella spiralis were discovered by Rudolf Virchow in 1859 and Frederick Senker in 1860, who finally recognized the clinical importance of infection and concluded that humans become infected by eating raw meat infected with the parasite. The epidemic of this zoonosis is very particular, since the domestic and wild cycle of the Trichinella spiralis have been clearly studied. Between them is the synanthropic cycle. In the domestic cycle shown on the picture, the main transmission vector to humans is the pig, through the ingestion of meat infected with Trichinella spiralis. In the wild cycle, Trichinella spiralis is kept in the environment by predatory and scavenger animals and can enter the domestic cycle accidentally. While in the synanthropic cycle, animals such as rats, cats, dogs, foxes, mustelids, among others, act as transmission vectors for the different Trichinella genotypes involved in any of the two mentioned cycles. After 10 to 30 hours post-infection, Trichinella spiralis L1 mature to female and male adult worms, as shown on the picture. Approximately 7-day post-infection, copulation occurs between female and male adult worms. Embryogenesis lasts about 90 hours since the newborn larvae of Trichinella spiralis are released. These newborn larvae of Trichinella spiralis possess a stylet in the oral cavity, which they use to internalize within the epithelial cells of the host, penetrating the submucosa of the small intestine migrating mainly through the circulatory system to various organs and subsequently invading the musculoskeletal cells, causing tissue damage. Only the newborn larvae of Trichinella spiralis that invade the musculoskeletal cells can survive and grow, giving rise to the muscle phase of the infection. During the muscular phase, the newborn larvae of Trichinella spiralis are in the muscle fibers, destroying them partially, as shown on the picture, and begin a period of post-embryonic development, growing and developing exponentially. Approximately at 15 days post-infection, the formation of nurse cell is induced with a fusiform or elongated aspect containing in its interior one or several L1 Trichinella spiralis, forming the NCL1 complex. The nurse cell formation process is a complex process and includes the cellular response of the infected muscle, from differentiation with a complete loss of the myofibril organization, re-entry and the rest of the cell cycle in G2M, as well as responses of the nurse cell. The cell undergoes activation, proliferation, redifferentiation, and fusion processes with each other or with the infected muscle cell. Since the satellite cell is a progenitor cell located within the capsule wall, a new cell can be continuously delivered from the myoblast, even if the present nurse cell dies. This explains why nurse cell seems intact and active for years despite intracellular parasitism. In this way, the parasites use the muscular mechanism of cellular repair of the host to establish parasitism. Trichinella spiralis develops its infectious agent approximately between days 21 and 30 post-infection, and 6 months after infection. The deposit of calcium begins in the nurse cell walls, calcifying in 1 year. L1 Trichinella spiralis can be retained for several years depending on the host species. L1 Trichinella spiralis appears to be non-pathogenic for natural hosts except for humans. The main striated muscles where the L1 Trichinella spiralis is implanted are the most active, such as the diaphragm, masseter, intercostals, eye muscles, muscles of the tongue, and anterior and posterior extremities, as shown on the picture. The clinical pathology of Trichinellosis can be divided based on the phases of the Trichinella spiralis life cycle. Infections with low parasite burden can remain asymptomatic, while high parasite burden can cause gastroenteritis associated with diarrhea and abdominal pain, approximately 24 to 48 hours post-infection. The intestinal phase of Trichinellosis is clinically manifested by presence of signs, symptoms, and gastrointestinal disorders such as malaise, mild transient diarrhea, nausea, vomiting, abdominal pain, chills, and fever due to the invasion of L1 Trichinella spiralis and AD worms in the intestinal mucosa. These signs and symptoms usually persist from the first to the third week post-infection, depending on the dose of L1 Trichinella spiralis and the severity of the disease. From 2 to 6 weeks post-infection, the intestinal phase is still present, but the signs and symptoms that correlate with the intestinal phase decrease and the signs and symptoms of the migration phase appear. During the migration of newborn larvae of Trichinella spiralis, which starts approximately 1 week post-infection and may last for several weeks, the first signs and symptoms to be clinically detected usually include myalgia, high fever, chills, a state-like paralysis, periorbital and facial edema, conjunctivitis, pain, skin rashes, and others. Other signs and symptoms are conjunctivitis, including subconjunctival hemorrhages, headache, dry cough, petechial hemorrhages, and painful movement disorder of the eye muscles. Some patients present urticaria, maculopapular rash, and subungual hemorrhages caused by vasculitis, the main pathological process of Trichinellosis. Laboratory studies reveal a moderate increase in white blood cells and circulating eosinophilia ranging from 5 to 50%. During the muscular phase of trichinellosis, signs and symptoms such as myalgias, astralgia, headache, periorbital and facial edema appear. The damage of the muscular cells stimulates the infiltration of inflammatory cells, mainly eosinophils. A correlation between levels of eosinophils and serum muscle enzymes such as lactate dehydrogenase and creatinine phosphokinase has been observed in patients with trichinellosis, suggesting that muscle damage may be mediated indirectly by these activated granulocytes. Therefore, progressive eosinophilia is the most relevant clinical finding of the muscular phase of trichinellosis. The invasion of the diaphragm and accessory muscles of respiration by the parasite results in dyspnea. In the chronic phase of trichinellosis, after 4 weeks post-infection, a series of complications such as encephalitis, bronchopneumonia, and sepsis arise. The early clinical diagnosis of trichinellosis is quite difficult due to the lack of symptoms and pathognomonic signs. In addition, chronic forms of the disease are not easy to diagnose. When the infection occurs in episodic or outbreak form, its diagnosis is easier. However, it is difficult in low-level or sporadic infections, since the clinical picture is usually common to many other enteric diseases. This makes it necessary to carry out a differential diagnosis. The diagnosis of trichinellosis must be based on 3 main criteria: clinical findings, the recognition of signs and symptoms, laboratory parameters such as eosinophilia and muscle enzymes, detection of antibodies or detection of L1 trichinellosis spiralis in muscle biopsy, and epidemiological research, identification of the source and origin of infection and outbreak studies. Identification of L1 Trichinella spiralis in muscle tissue is the positive diagnosis of the disease. Any technique used for this purpose is included within the so-called direct diagnostic methods, which performed post-mortem and includes 4 main techniques: plate compression, polymerase chain reaction, PCR, artificial or enzymatic digestion, and histology. Currently, trichinellosis is a re-emerging zoonotic parasitic disease that continues to affect the health of both animals and humans worldwide. For these reasons, it is important to know well the biology of its etiological agents, Trichinella, as well as its mechanisms of evasion of the host immune system, with the purpose of making a timely and differential diagnosis to achieve a good treatment. Simultaneously, it is necessary to continue investigating therapeutic strategies that, through pharmacotherapy and immunotherapy, develop specific treatments directed to the parasite, avoiding collateral effects to the host. Thank you for your attention.